All right. So, as I just said to everybody, thanks for being here tonight. This is the February 18th, 2025 session of Trauma Nursing Journal Club. It's our first Trauma Nursing Journal Club of 2025. If you're not familiar with Trauma Nursing Journal Club, we've been doing this for about 3 years. As we begin our third year now, I am extremely grateful to have not only a phenomenal article that's going to appear in the March-April
Come in here,
issue
baby.
of the Journal of Emergency Nursing, but also to have the authors here with us tonight. So, just as a matter of course, as we get started, make sure everybody has got your mute button on. I can mute you from here if I see you, but if you could just do me a favor, just double check, make sure you are muted. That'll be great. If any time during the conversation tonight you want to bring yourself off mute and ask a question, absolutely feel free to do so. The other thing we obviously have is the chat function. So I'll be doing my best to watch the chat function, and I've asked both Joe and Molly to do the same. So if we see anything pop up there that we want to kind of entertain and answer in real time, we'll do so. If not, we might wait more toward the end and try to answer those as we kind of have a little bit of a group wrap up. So anyway, tonight we've got a great article we're going to be talking about. I'm very excited again to have Joe and Molly here with us tonight. So a little bit about it. I've already mentioned the fact we're going to be recording this. It's going to go up on YouTube. For those of you that are not familiar with my YouTube page, you can find me on YouTube. I am the Trauma Geek. All right. So for those of you that don't know me, my name is Steve Wyman, and I am with the trauma program at St. Joseph's University Medical Center in Paterson, New Jersey. At St. Joe's, I am kind of a bit of a jack of all trades, but predominantly my boss has me doing trauma education, injury prevention, and a variety of other things, including a lot of PRQs right now for our trauma center re-verification, which is coming up in about 2 months. So we're hot and heavy into that. But I'm also, like I said, extremely grateful to have the authors of tonight's article here. So I'm going to have them introduce themselves really, really quickly. We'll start off with Joe. Joe, just quick introduction of who you are and a little bit about you.
Yeah, so Joe Blanchfield, spent my entire career in trauma and emergency nursing. Most of it as a started in the emergency department, worked my way through a variety of roles. You name it, I've probably done it. But the majority of it in the trauma program at the Boston City Hospital, Boston Medical Center, I was a trauma and acute care surgery program manager for decades, and was the first and continuously verified level 1 trauma program in the Northeast in New England, and started at Boston, and everybody else tried to copy us.
Amazing that they did a good job, didn't they? And Joe is also retired from the military. He achieved the rank of colonel in the U.S. Army Reserve. So thank you for your service, Joe.
Thank you.
And then Molly, tell us a little bit about yourself.
Yes, hi. Good evening, everyone. My name is Molly Bauer. I am going on probably this year 15 years in emergency and trauma nursing. I most recently moved to Indiana and currently working at the School of Nursing at IU. And I also just recently took a position as a trauma educator for IU Methodist, which is a level 1 trauma center here. Before doing that, I was a trauma educator in Phoenix for 3 level 1 trauma centers. And before that, I was in San Diego. I was a trauma nurse team leader, very involved in trauma, ended up doing my PhD research in trauma. So I guess that would kind of qualify me as a trauma geek as well. I'm happy to be here.
A kindred spirit. We love it. Okay, great. Well, thank you both for being here tonight. So, as we requisitely do, none of us, unfortunately, have anything to disclose, although we are working and trying to rectify that. And then, as is always there, the comments and views expressed tonight are those of myself as the moderator and our 2 guests, and do not reflect in any way, shape, or form the opinion of any of our associated agencies, organizations, and our employers. Although, after tonight, I think we'll agree that they probably should. All right, and from a continuing education standpoint, here's the requisite information that goes up for the CE credit that you can claim. Only people who are attending the live program can claim this credit. Toward the end, I will put a link in the chat box, and I'll also have a QR code that'll pop up on the screen, and it'll take you to a SurveyMonkey where you can do your evaluation, answer all the great, tell everybody how great we did, and then you can give me your information, and then I will email you probably over the course of the next 3 or 4 days, a CE certificate, personalized for you and definitely suitable for framing. So be on the lookout for that as we get to the end. I'll give you that information. And if you're not familiar with the program that they run here, I run the Trauma Nursing Education Series. Tonight, the Trauma Nursing Journal Club is one of 2 components of that educational series. The companion program that we do is Topics in Trauma Nursing. Trauma Nursing Journal Club, as you can imagine, really looks at articles that I glean from the literature that are of interest to trauma, but emergency/trauma nurses. Topics in Trauma Nursing is a much more clinically based topic that we talk about topics of interest in clinical trauma nursing and emergency nursing. If you are interested, and after tonight, when you're doing your evaluation, in the comments box, just let me know that you want to be put on my email list if you're not already on it, and I will put you on there, and you will be put in the queue for future emails when we are getting ready to do sessions in the future. And one such session is Topics in Trauma Nursing, and that next session, or the first session for 2025, is going to be held on April 9th, so still a little bit down the road. But we'll be meeting at 8 o'clock on April 9th, and this is Eastern time, as it is tonight, and we're going to be doing assessment and intervention for hemorrhagic shock. I love talking about shock, so I always try to start off my year doing some derivations of shock or shock-related things. So certainly, CPR and trauma certainly is shock in its nth degree. And then, of course, Amber Bottal, who is the trauma educator for Robert Wood Johnson University Medical Center, just down the road here from me now in New Brunswick, will be doing a nice talk on hemorrhagic shock. So if you are interested, there is a QR code there. You can very quickly snap that QR code. And again, if you give me your information in the evaluation tonight, if you let me know you want to be put on the email list, I will make sure I email everybody a copy of this particular image, and you can sign up after the fact tonight. So that's Topics in Trauma Nursing in April. And then I'd be remiss if I also didn't put a plug out there for the New Jersey State Council's ENA's annual Emergency Care Conference. We're going to be holding that 1 month from tomorrow in beautiful Atlantic City. We're going to be at the Hard Rock Hotel and Casino. New Jersey ENA has the dubious distinction of having the largest emergency nursing conference outside of the national meeting for ENA. So we have somewhere around about 400 participants every year that come and converge on Atlantic City, making it the safest city in New Jersey for 4 days. And it's a phenomenal conference. So if you are in New Jersey, Delaware, Pennsylvania, New York, anywhere for that matter, and just want to fly to the East Coast and hang out in Atlantic City for a couple of days, then you can click on that QR code, or you can go to New Jersey State Council ENA website, and you can register there. It is a phenomenal conference, and I wholeheartedly recommend it, not because I'm on the planning committee. All right, so let's talk a little bit about Journal Club. So these are the rules of Journal Club, much like the rules of Fight Club, all right? The goal of Journal Club is typically to review current literature as it pertains to the practice of emergency nursing, trauma nursing, and emergency nursing. The goal is really to evolve an evidence-based trauma nursing practice model for all of our nurses that are operating in the emergency department, and particularly those that like to think of trauma nursing as their specialty or subspecialty. It also can give people, depending on the article, ideas for possible research or publications down the road. We've had at least one participant who actually did take some of the information we did from one of our research papers and actually is doing a very small replicate of a study in her own emergency department, which is great. It also helps us to enhance best practice implementation. And obviously, above all else, if you know me, I'm pretty much a little social guy when it comes to, getting out and and mixing it up with our colleagues. It gives us a chance tonight to professionally socialize among what I like to call like-minded colleagues out there in the trauma world. And last but certainly not least, it gives us an opportunity to learn some stuff, which is always a good thing, given our chosen vocations. And one more shout out before we get into it. So Joe, myself, and Molly, we also are on the editorial board of the Journal of Emergency Nursing. So we are always looking for potential authors. Joe and Molly were phenomenal in putting together the article that is out here tonight. And Joe and Molly will both tell you, and particularly Joe, because he was the brainchild of this topic. It is an absolute labor of love to publish, but it's an absolute kick in the butt to be able to get yourself out there and get published and get out there in the public domain. So anybody who's out there who has any kind of interest in writing an article for the Journal of Emergency Nursing, please don't hesitate to reach out and let me know. The website for the journal is on there. This is an extremely user-friendly journal. We've got a journal advisory team that will basically talk you off the ledge and get you into writing a really cool article that you can submit for publication. So if you are so interested, please, you can reach out to me, reach out to Joe, reach out to Molly. All of our contact information can be found at the journal's online site. All right, so let's get into it. We're going to talk about a topic which is absolutely, I think it's probably one of the best topics we've done in Journal Club. The title of the paper that Joe and Molly authored is CPR in Traumatic Arrest, Time to Question Our Practice. And this came out of some conversations that Joe and Molly and I had going back a number of months ago. And it comes on the heels of some great work Joe has done and some talks Joe has done through ENA talking about the very similar topic. So it was great that they got together. They co-authored this paper, and are going to expand the reach of what I think is an extremely, extremely important topic. The introductions on there was just a note to myself to make sure I got Joe and Molly to introduce themselves earlier, which I already did. So let's talk a little bit about the paper. And hopefully, again, everybody read it. Everybody should have gotten a copy of the paper. And hopefully you had enough time to read it and digest it a little bit. So as part of their introduction, both the authors, aptly kind of put exactly, what's out there when it comes to us as professionals. That when it comes to medical professionals, year after year after year, nurses are looked upon as being the most trusted of all the professions that are out there, which is something we should all pat ourselves on the back for. And we want to make sure that, in maintaining that most trusted profession, that we are always out there, we're learning, we are lifelong learners, and that we are appropriately questioning practices that are not going to possibly benefit our patients. We're being advocates for our patients. And we all are. We all know from the time that we were nursing fetuses that it was drilled into our head through nursing school. And then the first year you were out, and then every year thereafter, is we are advocates for our patients. So that's why I think tonight's topic is so great, because we can become the most trusted advocates for some of the patients that are, in the most despicable time of their life. I mean, traumatic injury or maybe traumatic cardiac arrest. And both Joe and Molly aptly set out, and I think they were successful in basically, presenting some objective findings, items that were based in the literature, and then providing their own supporting rationales as to, really why CPR in traumatic cardiac arrest needs to be given some reconsideration by us, by our physician colleagues, and even our pre-hospital colleagues. So they start off the paper with that requisite term that every trauma paper in the last 15 years starts off with, and that is the fact that the number one cause of preventable death in trauma is uncontrolled hemorrhage, and that's so true. Statistics show as high as 64% of patients that die from traumatic injury die as a result of uncontrolled hemorrhage, and therefore their deaths are considered to be preventable. So anything that we can do when it comes to recognizing uncontrolled hemorrhage and intervening as quickly as humanly possible will absolutely save lives. We've seen this most ardently in the Stop the Bleed initiative, which has come out in about the last 7 years through the American College of Surgeons, the Department of Defense, and the National Association of EMTs. And we see that, uncontrolled external hemorrhage can be very easily mitigated by lay people and by first responders, and can result in many, many lives saved. And we are seeing that pay dividends. So now we've got to ratchet it up, and we've got to move to those types of hemorrhage that maybe are not as compressible, and things that are amenable to treatment in the pre-hospital setting, and then ultimately treatment in our trauma base. And that's going to be kind of more truncal hemorrhage, or hemorrhage that is non-compressible. They did a great job of going through and kind of differentiating and using their table to differentiate the differences between medical cardiac arrest and certainly traumatic cardiac arrest. And again, I think we all are out there, and we all have enough experience to know, and have seen multiple cardiac arrests that are medically oriented. But the question becomes, those of us that have seen traumatic cardiac arrest, have we ever really taken a step back as that patient is brought in, as the EMTs or the medics are doing CPR, as we transition over and we either start doing CPR or we put them on a Lucas device? Do we ever think, why are we really doing chest compressions on these individuals? And is it really making a difference? Are there other things we need to be thinking about and getting less tunnel visioned on that might benefit these patients greater, right? And we need to be able to differentiate that there is a difference between a medically oriented cardiac arrest and that happens as a result of traumatic injury. From a historical perspective, and this again, no surprise. And if you think about it, some of us, and I can tell by seeing some of you before you went off camera, we've got some scope of practice time behind us. I saw some people out there that have certainly been practicing as long as Joe and I have, and some that probably have only been practicing a couple of months. But if you think about it, for all the number of times we've ever taken CPR, participated in a CPR class, I've never, ever, ever heard them advocate CPR in traumatic cardiac arrest. And so, both Joe and Molly bring it straight forth. CPR has not been recommended in patients with traumatic cardiac arrest. And again, boom. Does that blow your mind? It probably shouldn't blow our minds when we think about it. And when we think really about the fact that, hey, you know what? There's some differentiation that we need to think about when we're thinking about our patients that come in, they've suffered some kind of a medical episode leading to a cardiac arrest, and those that are coming in status post a traumatic injury and are now, unfortunately, going into traumatic cardiac arrest. And they did a really good job of breaking it out. Just like we kind of think about when we're looking at cardiac arrest and the ACLS algorithms and kind of the H&Ts for PEA, they've broken that out and they put that in perspective for traumatic cardiac arrest as well. And, at the end of the day, when we look at traumatic cardiac arrest, is it reversible? Well, sure, it can be reversible. And it can be reversible if we chip on things very quickly, if we can get definitive treatment to these patients as quickly as possible, and we don't get tunnel vision. We think about what is the patient needs. And CPR and epiboluses is probably not the way to go when that's not the root cause of their cardiac arrest. So again, I think Joe and Molly did a great job of putting it in perspective of saying, hey, look, somebody comes in with hypovolemic shock. Stop, think, what's going on? Hey, stop the hemorrhage, stop the bleed. If we can do that. If it's uncontrolled external bleeding, then put pressure on it, right? Direct pressure, wound packing, tourniquet, right? If it's truncal bleeding or bleeding that's non-compressible, then what do we need to do? Facilitate movement, maybe restore preload, maybe get volume on board, but not giving them the wrong volume, right? The old crystalloid boluses that some of us remember giving all those years ago that we were popping in 4 and 5 liters of crystalloid to our patients. But no, volume and resuscitation now is centering itself around blood. And we're going to talk about that in a little bit because they did a really good job of talking about that further down the road from a treatment perspective. Again, hypoxia, establishing an airway, and oxygenating and ventilating the patients, extremely important to do, all right? A lot of these things are amenable to the fact they're in shock because they're not getting oxygen. Why are they not getting oxygen? And trying to get to the root cause of that, okay? Tension pneumothorax, tension physiology. Again, a big keeper out there. Both tension pneumothorax and then we don't want to forget about a tension hemothorax that can also develop in some of our patients. Any of these things create a form of obstructive shock. And as we all know, obstructive shock is not amenable to epinephrine. It's not amenable to giving a lot of fluid to. It's amenable to treating the root cause, treat the underlying cause. And in particular, where you've got your tension physiology with a tension pneumothorax, it's either a needle or a finger thoracostomy or insertion of a chest tube. And where it's tamponade, which is really technically another form of tension physiology, then that is relieving the pressure around in the pericardial sac that's leading to the compression of the ventricles and causing a drop off in cardiac output. So all of these things are very goal-directed. They are things that we don't want to lose sight of when our patients come in status post-traumatic cardiac arrest. And at the end of the day, these things, as we sit here and now in 2025, are not just amenable treatments and therapies that we can start in the emergency department, but we've now got tenets for doing this in the pre-hospital setting, all right? So for those of you that are practicing in the pre-hospital setting or have an interest in the pre-hospital setting, we know all the rage out there now in the pre-hospital world is blood. We are finally getting to a point where we are seeing EMS agencies come online in pretty decent numbers over a period of days to weeks to months that are now doing pre-hospital transfusions. Places like Texas and Florida and North and South Carolina, New Orleans, Washington, D.C., and now even up into Massachusetts, just a little bit north of where Joe lives, they've implemented pre-hospital blood. And the outcomes have been nothing short of miraculous. Several papers that have been published that have come out of New Orleans have shown upwards of a 40% decrease in mortality in hemorrhagic patients when given pre-hospital blood components pretty close to point of injury care. So again, these are things that now we are taking definitive care. We're putting them in the pre-hospital environment, and we're letting our pre-hospital colleagues work on that. And that's true for anything that's hypovolemia related, anything that can be airway related, and certainly anything that can be tension related through tension pneumos. We're still not to the point yet where we're doing tamponade remedies in the field. That's still combined to the hospital and to the trauma base. But you know what? Maybe only a matter of time till we even see that coming soon to a theater near you. But the reality is we need to identify and we need to intervene for those items that we can immediately treat and can preserve life. And I think, again, both Joe and Molly did a great job of bringing that out in their talk on the H and the T's. As they got into a good review of the literature, they went all the way back to 1982. Some of you probably weren't even alive in 1982. Some of us were just at the beginning of our practice in 1982. And we do remember some of these papers that came out from Maddox and Feliciano back in 1982. And it was a very small cohort that they published at that point in time. But in their series of 100 patients with CPR post-traumatic cardiac arrest, there were no survivors. And their conclusion at that time, even with that small sample population, was CPR provided no survival benefit. And now ebbs and tides over the years as to what papers you look at and what people think about when it comes to outcomes from traumatic cardiac arrest and the use of CPR. But pretty universally, the vast majority of the literature really does point to no survival benefit. Back in 2013, so about 10, 11 years ago, 12 years ago now, the National Association of EMS Physicians and the American College of Emergency Physicians put out a joint position paper. And once again, they recommended not getting tunnel vision, not just going to CPR for traumatic cardiac arrest, but really looking for things as signs of life, as criteria as to whether or not to resuscitate these individuals in both the pre-hospital environment and more ardently in the trauma bay resuscitation things. And again, they put together a nice chart which really kind of symbolizes what the paper thought about what constitutes signs of life, and kind of an algorithmic approach to where when is dead and when is dead not so dead. So again, I hope you all had an opportunity to look over the chart. I think it's very pragmatic. It does make a lot of sense, but it kind of makes you think this is something that was published now well over a decade ago. Why are we still not thinking along these lines? We've got the EMS physicians, we've got the emergency physicians on board. Where is this stalemate? Where are we getting the discontinuity and why we're still doing what we're doing when that traumatic cardiac arrest comes in and we're continuing to do CPR and follow the ACLS algorithm for these patients? Continuing in the review of the literature was some information that came out from the European Resuscitation Council. And again, it identified the fact that if we're going to treat patients status post-trauma that go into cardiac arrest, we need to be readily identifying and treating reversible causes of the traumatic cardiac arrest, okay? And they particularly mentioned, again, management of hemorrhage and restoring preload. Again, up to 64% of trauma-related deaths are hemorrhage-related, so it certainly is a logical pathway to be considering. And particularly now in 2025, when we are better than ever with doing hemorrhage resuscitation and not using the clear stuff, but using the blood stuff. So, really when it comes down to it, and you do the review of the literature, it really is wire chest compression still on everybody's list. And I think, both the authors did a really pragmatic approach as to why these are happening, all right? We know in trauma care, old habits die hard, right? I mean, nothing could be more representative of that than, again, how we're doing fluid resuscitation. How we went from years and years and years and years of using that white pasta water or bags of acid, as some of us like to call it, and have migrated away to when you're bleeding blood, you're being resuscitated with blood, okay? So old habits certainly do die hard. there hasn't been a plentiful amount of information in the literature to support some of these things. And I think a lot of it coming out of the military over the course of the last couple of decades have really kind of moved the pendulum forward 100 years in the way we're treating our trauma patients. I'm going to throw this back to Molly very shortly when we talk about heuristics, because I had never heard of this term before reading this paper. I had to go and Google it and Wikipedia it and everything else. So I'm going to let her, because I believe she's the one who came up with this for the purposes of the paper, and discuss kind of where heuristics kind of bleed in, pardon the pun, on why we are still treating traumatic cardiac arrest as we do. All right. There are some that say they're already dead, so what harm is CPR going to do? Well, the reality is, if you really consciously think about it, you critically think your way through the differences between traumatic cardiac arrest and a medical cardiac arrest, what harm can you do? I don't know. CPR is not a benign procedure, all right? How many of you have been able to get on somebody and do CPR where you haven't broken multiple ribs? You haven't cracked a sternum. You haven't probably caused a pneumothorax. You haven't lacerated a liver. You haven't hit a spleen, right? Trust me, if you've been doing this long enough and you've been doing CPR long enough, you have done that many a times on the patients. You just didn't know you did it because they were dead, right? So, at the end of the day, what harm can we do? Well, we can actually do a considerable amount of harm. People's protocols are driven by this. We're very much a cookbook medicine environment in some cases. And if it's part of the protocol, get on scene, find no pulse, it's jump on chest and do CPR. There's not a lot of critical thinking sometimes it's allowed to play itself in there as well. There is a fear of litigation. We're a litigious society in the United States. The logic is, if we don't have documentation that we tried CPR and this goes to an attorney, the attorney's going to come back and say, well, why didn't you do CPR? CPR is what you're supposed to do when your heart stops. Even though, again, there's a bountiful enough literature out there and some very high names in the trauma world and the emergency medicine world have done some of these studies to say, hey, there is not a big survival benefit for doing CPR, right? And, you're right. Joe just popped a comment in the box. He's spot on. It's not just harm. You're just not helping. You're just not doing any good. If you're pumping somebody, particularly a hemorrhage patient, and there's no fluid left in the radiator, and you're just popping on that radiator, to what good are you really trying to do? And how effective are you doing things as well? And then there is a fear of outcry. I have had EMS clinicians tell me, we did CPR because if we didn't, people would get mad at us. They'd start throwing it. They'd rock our ambulance. So we did it just for the show. It's like, I understand that. So maybe the key is you don't stay on scene very long. You get the patient, you get them in the back of the rig, you close your doors, and you get away from the scene. And then you treat them how is most appropriate. But again, protocol-driven things tend to be kind of somewhat problematic, even with that environment. So we've got to change. There's about to be a paradigm shift in the way we think about things. And we have to think about traumatic cardiac arrest as an entity separate from medical cardiac arrest. And I think, again, this resonates throughout this paper. And again, it's not a benign procedure. So when it comes to vital signs and signs of life and stuff like that, again, a nice little summary is provided within the paper that talks about kind of vital signs and how those are integrated, how signs of life and how those are integrated. And again, a lot of it does boil down to what are the tools that are available to us and what are the tools that are not available to us. And then it always comes back to what we have learned for all of us as trauma nurses from day one of going into the emergency department. It always starts off with that primary survey, right? Start off with the primary survey. It's not going to lead you down the wrong road, all right? You always think about it and you always put that in perspective. As we were teaching TNCC today and going over the trauma nursing process with a lot of fledgling new trauma nurses, it was really take it back to the basics. Always, always, always think about that primary survey. It doesn't lead you wrong. And we've already talked about controlling catastrophic external bleeding. Anything that's compressible, let's compress it. Direct pressure, wound packing, tourniquet applications. Absolutely, we're saving lives as a result of that. Airway mitigation. Make sure that you have got a good airway in your patients. I can't tell you the number of times patients come into our emergency departments, come into the trauma bay, and they're being bagged, but there isn't a nasal pharyngeal airway in them. There's not an oral airway in them. They're just basically, we're just holding their airway open by one person trying to mitigate a bag and a mask and try to deal something with that. So make sure that we're doing good airway management. Make sure that when it's appropriate, if we're not going to intubate the patient because that isn't a high priority because we've got a good airway, make sure we maintain a good airway in that patient and make sure we're adequately ventilating that patient. If we're having issues ventilating that patient, we're having issues with that airway, then mitigate that risk moving forward. All the CPR in the world isn't going to help if you have absolutely got no airway. You've got no oxygen going into the patient. And then the definitive care, blood resuscitation, particularly when we're talking about our hemorrhagic patients. Okay. Everyone who's taken any kind of a remedial course in shock management in trauma patients in the last 4 or 5 years have been bestowed about the virtues of blood, giving blood, whole blood, or component therapy. All right. This started again as a result of the military kind of taking things and kicking it back and helping that pendulum swing forward to what we do now in our pre-hospital environment with the application of blood therapy. So, for those of you that are working in, different environments, do you guys carry blood? Where do you carry your blood? How quick does it take you to get blood down to your emergency department, your resuscitation room, your trauma resuscitation bay, and work on things within your own system that might allow you to get blood more quickly into the emergency department than it currently does. Because God forbid somebody comes in and they're in traumatic cardiac arrest, one of the things we're thinking about is we need to be giving them blood, not the clear stuff. That's not the stuff that saves lives. No way, no shape, no form. And also understand that when you're giving component therapy, you need to give equal portions of the components. Giving a patient just a bunch of red blood cells isn't doing them any good. They need to be getting all of the constituents that make up blood, whole blood. And that's plasma, it's platelets, it's the clotting factors that come with that, and it's obviously the oxygen carrying capacity that's there as well. Okay. The earlier we give blood products, the better the outcomes are going to be. We're seeing that now that a lot of the pre-hospital assets that have been now using blood in the pre-hospital setting and are starting to publish their data is certainly showing, just large decreases in trauma mortality in their hemorrhaging patients. Okay. So for us to be doing that, for us to be making that impact in that pre-hospital setting is telling us we're heading in the right direction. So let's continue to head in that right direction. For those of us that don't have blood readily available, whether it's in the pre-hospital setting or in our emergency departments, then making sure we don't over-inundate these individuals with crystalloid, right? Small aliquots of crystalloid, just enough to kind of give some semblance of a preload if it's needed until we can get blood or blood components down into our resuscitation base. And then definitive treatment as it gets even more invasive, right? How many of us have done the good old cracking of the chest in the emergency department, right? For those of us in trauma centers, it's unfortunately still way too commonplace. For those of us that are not working in trauma centers, hopefully you're not cracking too many chests in your non-trauma environment. But, nothing gets more invasive in a trauma center in the trauma resuscitation bay than cracking a chest. Whether you're doing a left-sided thoracostomy or you're extending that incision all the way across the chest and doing the good old clamshell thoracotomy, then that's certainly a highly invasive way of getting into the chest and trying to figure out how to mitigate hemorrhage, trying to mitigate any kind of injuries that could be amenable to quick intervention in the thoracic cavity or cross-clamping the aorta, preserving the flow of blood to the vital organs until you can hopefully resuscitate the patient, give some fluids, and then maybe get them, if you get Ross back, to the operating suite. Resuscitative endovascular balloon occlusion of the aorta. Boy, you both had to go there, didn't you? The REBOA. Oh, I was doing really well with this paper until I saw that word REBOA come up. Brakes went on. No, I'm just kidding. So for those of you that don't know what REBOA is, it's a procedure. It's basically the passing of, sorry about that. It's basically the passing of a balloon tip catheter up through the common femoral artery, beyond the bifurcation of the aorta, and then somewhere either in the lower third of the aorta or the upper third of the aorta, basically internal balloon cross clamping of the aorta without having to crack a chest. There's been a lot of papers that have been written on the virtues of REBOA and whether or not it does result in some kind of survival benefit, whether or not it's quicker to do a Reboa or it's quicker to crack a chest. And the papers, you can imagine, it's all over the place with the pros and the cons of doing Reboa or not doing Reboa. So I'm not going to certainly go down the rabbit hole, which we often do when we're talking about Reboa, and get too much into it. If you're interested in learning more about Reboa, then go to the literature, read up on it, see what's out there. And we can certainly open it up for a little bit of conversation toward the end if anybody wants to chat about this. And then the last thing that was in there that I found very, very interesting, because I've actually come across a couple of papers that I've reviewed for in another journal that I serve on the editorial board, the Journal of Special Operations Medicine. And there have been some really interesting data, some nice case study groupings coming out of the Ukraine for the use of what's called an abdominal aortic junctional tourniquet, or an AAJT. And for those of you that are not familiar with that, unless you're probably in the pre-hospital environment or you're military or you've done some tactical pre-hospital work, you're not going to be familiar with what these junctional tourniquets are. But this tourniquet in particular is a tourniquet that I'm going to date myself with saying this, but it almost looks like Batman's utility belt, or a World Wrestling Federation belt. It's this giant circumferential belt that goes around the abdomen, usually around the level of the umbilicus. It cinches down, and it actually cinches really tightly against the abdomen through a similarly tourniqueting effect. And then it's got an inflatable bladder on it that you inflate the bladder, and the bladder comes out of the bottom of the belt, and it actually pushes into the abdomen about 6 to 8 inches, and externally it compresses the aorta. Okay. It'd be a fin of just taking your fist and putting it below someone's belly button, all right, and pressing as hard as you can, literally trying to press all the way down and press the abdomen against the vertebral column. They've had some limited success in the Ukraine war, as well as even with our own military, with regards to patients that had hemorrhage, truncal hemorrhage that wasn't thoracic in origin, where they've actually applied this and actually been able to establish ROSC as a result of using it in traumatic cardiac arrest. Like I said, there's probably about 4 articles that have come out or been in for review for JSOM that have talked about it. And it's really getting some people, particularly in the tactical environment and the military environment, thinking maybe we need to pay a little bit more attention to this particular device. It's a non-invasive device, but it's pretty expensive. They run about $300 to $400 to purchase one of these things. They're one-time use only, unfortunately. So there's a cost factor that's there. But if some of the data that's coming out of the Ukraine is true, and I do believe that it is, there may be a limited utility in maybe having these things under certain circumstances. So, and we can talk about this either offline or a little bit more if you've got some interest in that. But these were a couple of additional intervention, definitive treatment things that Joe and Molly went into. And again, it all falls into what can we do quickly and what do we need to do to be restorative to the underlying traumatic mechanism. And again, I think that kind of, caps it off as to what we could possibly do from minimally invasive to maximally invasive. And then again, they, I think, do a good job of kind of summarizing the article toward the end. Critical thinking is a must. You need to be thinking, why are we doing this? And again, I'm going to compare and contrast this to all the years that I was working in the pre-hospital environment and in the trauma resuscitation base, where we were given all of that clear fluid to patients. And we would have a patient that would come in from the field. EMS was high-fiving themselves because they ended up getting about 3, maybe 4 liters of normal saline in the patient before they got to the hospital. We continued putting up some normal saline while we were waiting to maybe get some blood. And then we were doing what? We were starting a second line or a third line or drawing blood and getting kind of this pink tinged Kool-Aid looking stuff that was coming out of people's veins. And at that point in time, it just didn't dawn on us that this just didn't look right. And for decades, we continued down that road of doing this and saying, this just doesn't look right, until we just came to the epiphany, it's not right. And we made that better. So critical thinking is important. Discussing things is extremely important. Making sure your interventions are as evidence-based as possible, extremely important. I'm going to turn this over to Molly in just a second to talk about this heuristics, because I do want to hear kind of from the mouth of Babe on that. And obviously making sure that we debrief just a little bit after all of our resuscitations if possible, just so we can discuss best practices, what went well, what didn't go well, and we can learn from our mistakes or from hopefully our successes. So Molly, talk a little bit about heuristics. I'm kind of interested in this now that I've seen it in the paper. So give us kind of a bit of a summary of what we're going well with this.
Sure. Yeah. So heuristics are essentially just mental shortcuts and rules of thumb, just in general. It's anytime they're typically developed, anytime someone needs to make a rapid decision in high pressure environments. There's multiple different heuristics. There's survival heuristics. We see a bear coming after us. It's kind of that fight or flight. We think big, bad, and scary. We run. In the ED, it's usually just trying to make clinical decisions. And I know in my experience, kind of a rite of passage when nurses could look at a patient and pretty much identify what they were there for. So, for example, sick or not sick. You see a patient walk into the ED, they're sick, they're gray, they're diaphoretic. Sick or not sick, you're kind of creating a mental shortcut. You are observing these patterns of behavior and you kind of make a nursing diagnosis based on that. It could be something as like, a textbook appy. They come in with sudden onset right lower quadrant pain. It could be different things like latching on to a certain diagnosis. So, for example, assuming that altered patients that come in are intoxicated. There can also be like demographic heuristics and biases. So that's something I should preface is that a lot of times heuristics, these mental shortcuts often carry a lot of cognitive biases. Some of the demographic ones that I have heard in the emergency department, something like Hispanic panic, those who come from Hispanic background exhibit, um, lots of anxiety or dramatic behavior. Frequent flyer is a common one that we hear quite a bit. Drug seeker, end stage fibromyalgia. It's a common one the last few years. But essentially, what they do is they set us up for failure in making the wrong diagnosis or just attaching a label that may not be correct. And so tying this all back in to our paper is similar thing is, we get a patient in traumatic cardiac arrest. We see the heart stop. We have been trained in and out when a heart stops. You get on the chest, you do compressions, you do the epi, and you do that cyclic pattern. And so we're just trying to call attention to is these are heuristics, these are patterns, these are mental shortcuts that we have developed in our nursing practice that can easily translate over to traumatic cardiac arrest. But because of the biases, it actually can set up our patients for failure, as we know is the number one cause of um, death in trauma patients is hemorrhagic shock. And if we're pushing on a patient who is hemorrhaging, we're potentially making things worse.
Absolutely. Well, thank you for providing that. That really, I mean, everything you said totally resonated with us, and it's so true. So, and it really formulates itself really, really well against the constructs of your paper, because I mean, that's really what we're doing. We're being, very heuristic. Is that a word? When it comes to kind of how we're treating these patients, and we all know that when somebody comes in and they're in traumatic cardiac arrest, the survivability just is not great to begin with. But the survivability is not great to begin with. Is it because of us? Is it in spite of us? Or is it with us? And I don't know. I think this raises some really, really good questions. And I hope it raises questions that, anyone who's listening to this, that's on this session tonight, and anyone who listens to this after the fact really calls into full function. I know that the next post-resuscitative debrief that I go through, if I even see CPR being done on a patient, that's going to be the first thing that comes out of my mouth is, why are we doing CPR? Why are we got a Lucas device on this patient? And anybody who's ever, and when I go back to doing with the slide for the thoracotomy, how many of us have been in a room where thoracotomy was being done and somebody was still thumping on the chest doing CPR while they were doing the thoracotomy? I mean, again, talk about oxymoronism. I mean, they got a guy with a sharp scalpel who's bopping up and down while someone's doing CPR while he's trying to cut into a chest. It's like, come on. Sometimes we just can't get out of our way, even though common sense, we would like to say that it prevails. So, sometimes common sense isn't so common, right? All right. So look, at this point in time, not a lot of comments in the box. So either you guys agree with what I was saying, you're afraid to disagree with me, which you should never be afraid to disagree with me. My wife will tell you, disagree with me anytime you want. But pop up, tell us a little bit about what your experiences are, what your thoughts are with regard to the discussion tonight, with regards of what you saw in the paper, and what's happening in your emergency department when you see traumatic cardiac arrest. What's happening in your trauma bay? Are you still doing CPR, or are you enlightened in your emergency departments where patients that come in status post-traumatic cardiac arrest, you're not doing CPR? You actually have, the wherewithal to say, we're not doing any good, and we're not doing it. We are trying to find the root cause of why they're in traumatic cardiac arrest and deal with that. So again, part of this is getting a little bit interactive. You don't have to, but it'd be nice to do so. So does anybody have any thoughts or any questions or any thoughts on your mind?
Steve, so
Yes, ma'am.
I don't know, I'm probably going to get beat up for saying this, but one of the one of the things that first came to my mind, when reading it and looking it over is the table one, when you talk about medical arrest versus traumatic arrest. Of course, we all, kind of know those algorithms and practice guidelines that guide our care, penetrating versus blunt versus whatever. But I would like, or I wonder what everyone's feeling is, because I think I have definitely seen personally in my own world, even just last night, right, Steve, in our trauma room, where there's that combination of a medical arrest caused the traumatic incident, and then the patient is in arrest, but it's not a traumatic arrest. It's their STEMI. You know what I mean? I don't know if I'm making sense, but like we just had a gentleman last night who had an MI and crashed his car because he was driving. His poor wife just broke her humerus. It was a single vehicle accident because he just had a cardiac arrest behind the wheel, right? And so he was we did get ROSC and he's in the MICU now. And he really doesn't have significant traumatic injuries because it wasn't a high speed crash, blah, 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 blah. But that was a different time without a witness. It's like, and then I've also seen it where there was a police car, similar story, right, in my local town. A police officer drove off the side of the road and it was witnessed and somebody followed it because it was the police car, and it was a cardiac arrest, and it was also a save, thank God, actually a save from the field from the CPR. So I'm just wondering, I think, like you said earlier, the litigation and the fear of like doing nothing. I totally agree that we do too much CPR, and I wish we were all more enlightened, right? When it's really futile. But I wonder, how often is that? Because the blunt is the one that I have the hardest time with, right? Because those are the hardest to save, especially if it's a prolonged extrication, long time down in the field. Like when they come in with the Leukoson still doing CPR, it's like, those are the ones that are easiest to call. And I guess that should be our feeling, maybe, if you don't get that ROSC with the shock in the field or the first few rounds in the field, then it likely is more blunt. I don't know. I'm rambling now, but what are your thoughts?
Go ahead, Joe.
So these are great questions. And, life is not black and white. So, there are times when someone has an MI and then crashes into the bridge abutment. And, so you have to ask yourself, is this a pure cardiac arrest? Is it a pure medical arrest, or is it a traumatic arrest, or is it a combination of the two? So life is not that simple. So, when it's getting back to basics, history and physical. So when the patient first arrives from EMS, and I get it, I've worked in Boston for many years, and Boston EMS is a high speed operation, and they know what they're doing, and I trust their judgment. But just they're giving you their quick report. The guy crashed into the bridge abutment. Well, why? Okay, so he crashed, and then okay, let's make our assessment. Stop CPR. Stop CPR. Are there any vital signs? No, of course there's no vital signs. That's why we're doing CPR. Are there any signs of life? If there's no signs of life, okay, thank you very much. This is over. If there's signs of life, okay, well then we're going to proceed with that, and then we can, while we're proceeding with signs of life, then we're going down that little decision tree. Then we're asking a little bit more history. Okay, well, does he have PMH, mentality? So okay, well, he did have a heart cardiac history. Okay, fine. So again, trying to break away from the the knee jerk heuristic response and trying to sort of use our frontal lobes a little bit and trying to discern why this person drove into the bridge abutment. He didn't do it on purpose unless he was trying to kill himself. He might have had an MI. And then, okay, well, fine. So we're looking at his MI. But so, okay, so that's a blunt cardiac arrest that happened in front of you. a blunt traumatic cardiac arrest happened in front of you. Okay, so then a quick decision is no signs of life, or no vital signs, but signs of life. Open the chest, and then look for sources of reversible bleeding. And if there's none, then you clamp the aorta, and then you're at least you're trying to get back some of the ground that you might have lost. And then, then you're looking to try to fill the tank, and you're trying to, get some blood back to the brain, and you might do some manual compressions, whatever. But you have to try to dig yourself out of the hole. But first, you have to find out what kind of hole you're in. Is it a medical hole, or is it a traumatic hole? And I think it's not easy, but you know, um, I've been at the game for many years, and I was that guy, where I'm, you know, at the bedside doing all of the procedures, and hanging the blood and starting the IVs, and all of that stuff. And then as I got a little older and I got a little smarter, well, I didn't get smarter. I got wisdom. And there's this old cliche I learned about wisdom. How do you get wisdom? Wisdom comes from experience, and experience comes from screwing up. So, that's how I got a gray beard, because, you step back a little bit, and you're no longer the guy that's actually doing the procedures, but you're the guy standing in the back, sort of looking at everything. And you start looking at everything, and you start to scratch your head and you say, something's not right here. This just doesn't add up. And so then you're sort of trying to figure out, well, what are we really trying to accomplish? And then you have to ask yourself, well, are we pursuing a medical arrest, or a cardiac traumatic arrest, or not? I'm rambling now. I'm sorry, but um, it does take somebody with a little bit of a gray beard has to stop and say, what's the algorithm we're trying to proceed here?
Yeah, I get that. We'll get to you in just a second, Mary. So you got your hand raised, and I think that's a good point. Look, and for those of us that have a lot of pre-hospital experience, we get on the scene, and we try to, in the chaos of the environment, try to play a little bit of detective. And as Joe said, the guy just for whatever reason ran his car into a tree. There's no reason for it. You don't see skid marks anymore because we have anti-lock brakes, but there's no signs that anything was ever tried to slow down. What is going on? And one of the differentials that have to pop into your head is, was this a medical event leading to this crash, leading to this incident? So yeah, you've got to be thinking about it. And that's your critical thinking skills for sure. Mary, go ahead and go.
So I have a question. My name is Mary Bobeck, and I work at Hackensack University Medical Center. And I hope none of you kick me out, because I am a surgical ICU nurse by background.
Yay!
So I don't have any ER experience aside from one shift where I picked up double incentive in the ER, and I earned every penny that day that I went down many moons ago. But I guess my question is, because again, my background is critical care. When I receive these patients, they can be messy, but they've been nicely cleaned up by either the ER or the trauma surgeon at that point, when we are kind of focusing more of a trauma care after resuscitation situation. But I guess my question would be for figure 12, exactly the algorithm that Joe was just describing. I guess my question is, it makes perfect sense to me. Vital signs, no. Signs of life, no. That's dead. That makes sense. But I guess my question is, vital signs, no, but signs of life, yes. How often are patients coming in? Because I just wanted to clarify. I'm like, vital signs, is that essentially blood pressure, respirations, or does that include a pulse as well? And it looked like there was another table too that says vital signs is pulse, blood pressure, respiration. So how often are you seeing patients that are coming in pulseless, whether it is shockable, non-shockable, but are having agonal breathing and those signs of life? Do you see that a lot?
Excellent question. So Mary, thank you for joining us. Thank you absolutely for being our colleague up in the ICU. And thank you for your one shift in that monstrosity of an emergency department at Hackensack. Hackensack has not as dubious distinction of being, I think it's the 5th busiest emergency department in the country. So if you spent the shift down there, your one shift down there was probably the equivalent of about 5 years in a more tame emergency department. So look, I'm going to turn it over to Joe or to Molly to kind of go through and kind of put it in kind of the framework of the algorithm and answer her question.
Okay. All right. So thanks, Mary, because we, when I in my trauma manager role, I spent as much time I spent more time in the surgical ICU than in the emergency department, because the emergency department, for these traumatic activations, trauma team activations, it's 20 minutes in a cloud of dust, and then they go to the OR for 2 hours, and then they spend 2 days in the ICU where you're trying to put it all back together, and you're trying to figure out, well, what's really going on with this patient, and and are they still bleeding, and why are they still acidotic, and why are they still, why aren't they getting better? So I get all that. Okay. So to answer your question, so I think the first part is no vital signs, no signs of life, dead. All right. So then it gets a little sneakier. Okay. So vital signs, no, but signs of life. And the signs of life, as we've already described, pupils, um, QRS complex, and respiratory effort. So I think that just tells you that there's something that you can work with. Okay. That tells you that the patient is not clinically, physiologically, you know, brain dead and metabolically dead. It tells you that there's something that you can work with. Now, is there, no one's done any double arm studies or randomized controlled trials to figure out, what are their survival ones. But I can tell you that, anecdotally, that we have seen patients where you say, oh, they do have some signs of life yet. So now what are we going to do? Now we're just going to ramp up our game, and we're going to really be extra aggressive. And that's the patient that might require the thoracotomy. If you're in a fancy schmancy level 1 trauma center like Hackensack, that's where you're going to do the full court press, and you're going to go all in on it. But if you are in Memorial Hospital, somewhere in, central Western New Jersey, where the resources are a lot skimpier, you may not be able to do it as aggressive, because you may not have an OR 24 hours a day and that type of thing. So it just sort of sets the paradigm for which ones you're going to be more aggressive on treating. And that can be anywhere. Doesn't have to be in the emergency department. That can be actually in your ICU. If a patient arrests, you're going to say, okay, well, obviously there's no vital signs, but are we going to pursue this patient aggressively, because are there signs of life? I just reviewed a case. I do some consulting work. I just reviewed a case for a hospital that had a young female patient, pedestrian struck, high speed, 40 miles an hour. Had an obvious brain injury, came in fixed and dilated, but still had some kind of vital signs that they lost in front of them. They opened the chest for a blunt traumatic arrest. They opened the chest. They didn't clamp the aorta. They just opened the chest and started running it like an ACLS code. They started doing, they did epi, they did compressions, then they gave epi. And so guess what? The heart went from PEA, which they couldn't define what PEA was, whether it was, some sort of idioventricular rate at 12 beats a minute, but they gave epi, and then the heart fibrillated. And what they do, they had to defibrillate the heart. So they did all of this craziness for like 40 minutes, and then they pronounced this patient dead from a VFib arrest. And so I said, really? You have this 26-year-old female patient, high-speed motor vehicle crash, that came in with pupils fixed and dilated, and your cause of death is VFib arrest. Is that what really you want to put on this chart? And they had no answer. And they, so again, you have to sort of be careful which rabbit hole you're going to go down to, because, you have to back yourself out of that. So try to think about it before you go down there. I'm sorry for that ramble, but I hope that answered your question.
Hey, Joe and Steve, this is Brett Bajorn. I'm not sure you guys remember me. I used to work up in Bangor, Maine. I'm down in Gainesville, Florida now.
Yeah, hey, Brett, how you doing?
I'm good, thanks. Look, I think you just touched on something we all have about the differences between the pre-hospital arrest and the in-hospital arrest. And the rules, I think, are very, very different. And all which is to say that if you have blunt trauma arrest in the pre-hospital phase, the odds of any sort of functional recovery are pretty much zero for those patients, and that's been pretty well established for a long time. Penetrating trauma, you can get away with sometimes because you can find source control as soon as they hit the emergency department and rush into the OR. But I came from Bangor, Maine, very rural trauma system, and 15, 20 years ago, the state of Maine basically decided that there was no longer going to be any transport of CPR in progress. That regardless of the cause, medical or trauma, the best chance the patient had is if the pre-hospital crews worked them on the scene. There's no benefit really to hospitalizing those patients. And when they prohibited transport with CPR in progress, the survival rate from cardiac arrest from all causes went up. So even though we weren't bringing in the magical medical centers, the simple things in the field, the ACLS resuscitation for the medical arrests and the needle or the thoracic decompressions and the simple stuff for trauma arrests, hemorrhage control, and a bolus of fluids, sometimes created better outcomes. But I do think there's an important distinction here between the fact that most of the time, if your patient arrives with a pulse in the emergency department, there's probably an indication to do something for it, regardless of the cause of the pulselessness. But if that happens in the pre-hospital phase, the clock is ticking, and it's very, very difficult to create a success story out of those patients. And most of those are restricted to penetrating trauma. We do a lot of these in Florida, and I can't speak for everywhere else, but I can tell you that in Gainesville, we haven't the chances that a patient arrives without a pulse and resuscitates to functional recovery are pretty close to zero. If they can get any sort of ROSC on the way in, and sometimes we have a shot at some sort of at least cardiac resuscitation and letting the family say goodbye and maybe getting organ procurement out of it, the odds of functional recovery are still pretty dismal. But if they arrive without a pulse, if they have no ROSC, especially from blunt trauma, there's very little resuscitation potential, and therefore that it becomes a pre-hospital issue as well. And are we wasting resources? Are we taking a truck out of service that could be serving its community to travel for half an hour, 45 minutes to a hospital with CPR in progress for no gain? Anyway, I'm rambling now, but I do think that Joe, you've hit on the fact that it's a different conversation when you're in the ER versus when you're in the truck. And I hope we can, promote the idea of maybe not being so aggressive with trauma resuscitation at the scene. Some of these patients need to be pronounced.
Sure. So let me quickly respond. 2 points. So I think we're in agreement that blunt trauma is really bad. Penetrating trauma, you might have a shot. Blunt trauma is pretty bad. There's like little to no survivors. So what to do? You have to do whatever you think is the best. But the protocols are clear. The part of our research for this paper was, you look at the national protocols, and the national protocols do not advocate. I don't know about the Maine protocols or the Florida protocols. Even in Massachusetts, I gave this talk a couple of weeks ago, for our southeastern Massachusetts EMS rounds, and we do have blood in the field, and that was a good thing. But their protocols were still to do high quality CPR, which was terrible. So after I gave this talk, they're going to relook at their protocols. But if they reference the national protocols do follow the guidance that we've borrowed to make this paper. So I think go up the chain a little bit and try to look at whatever the national protocols. And I can't remember which, it may have been the National Association of EMS Physicians, whatever, but there are national protocols that are referenced in our paper. So I would look at that. My second point is that for whatever that blunt traumatic arrest happens, and I've even heard people say, well, let's do some soft CPR, just enough to perfuse the frontal lobe. Like, are you kidding me? That's like, being almost pregnant, like just a little bit of CPR, but not enough to exacerbate further bleeding and all that. Will that work? No. So the rare case that that we may have misconstrued or we may have underassessed or overassessed, or we missed something, but they survived because of some fluky thing that happened. And they may not have been able to do a Sudoku puzzle on discharge, but they survived the trauma bay. That gives us a confirmation bias. That says, see, CPR works. We have to do it. We have to do it. So I think, that's that sort of 1 in 1,000 or 1 in 1,000,000 cases that we say that's why we have to do it, because that case, I remember, it's the same story about the full moon. The full moon makes us crazy. That's all hocus pocus. It doesn't make us crazy. So don't fall for that confirmation bias. Try to stay with the try to stay with class 1 evidence.
Great.
Yeah.
The other thing that you mentioned, or somebody had mentioned in the conversation, was the Lucas device. And I also just want to editorialize a little bit there, because I think that if you are, again, back to the pre-hospital phase, if you are doing CPR in transit, you have to use a Lucas device. You just cannot do effective CPR standing up in the back of a moving truck. That's never going to work for the benefit of the patient, and it's incredibly dangerous for the people who are standing in the back of the truck trying to accomplish CPR. So, for those who cast aspersions on folks for using the Lucas device, that is exactly the indication for it. And we should be congratulating medics for making a good decision when they're using those.
Yeah, absolutely. And congratulating their systems for putting out the cash outlay for those things as well.
Yeah.
Excellent. Jeannie, your hand's been raised for a while. I don't know if you have any rambling you'd like to do.
I feel like I was contemplating taking it down. I had 3 notes kind of that I wrote, and I was going to talk about if no one was talking, but there's been such great conversation. One, I just wanted to kind of tag on to Joe's comment about, in the very early part of the talk, we were saying, what harm can CPR do? It can do a lot of harm. It's not even just the harm it can do, but also the utilization of resources. The other thing that I think is really, painful and hard for me to swallow, and that I, love Christian, our blood bank support at St. Joe's, but, sometimes these traumatic arrests can go on and on and on, and, 49 units of, product, and, the MTP that went on for an hour and 20 minutes, and, ongoing CPR. It's just the resources, the staff, the time, the effect on other patients in the unit when that much staff is designated that way, all those things. So we really can do harm. So I was just tagging on to what Joe said. It's not even just harm to the patient, but harm to our system in general, our whole system and whole ER. And then the other thing I wanted to ask, Brett, what state was that you were referring to with the no transport of CPR in progress? That was so interesting. I wanted to look up that.
That's I came out of Maine originally, and it was Maine Medical Center in Portland who actually piloted that for 6 or 7 months and found out that there was an incremental increase in survival when they let the medics do the work on the field, and didn't have people wait to get the emergency department to save the patient. And again, Maine's very rural. I think that's another point that you have to bring up, is that some of these transports are going to be really long, and just there are states with protocols that say, or with medical control that says, once you started CPR, you shouldn't stop. Sometimes in the rural, in the field, you have to be able to stop what you're doing and reassess the patient and see if futility is part of the conversation. So. But yeah, the protocols are in Maine. Basically, Maine EMS rules say don't transport with CPR in progress. If you have to start, you pull over, you do excellent CPR, and you focus on the resuscitation to the extent that you can do it. But if you're just trying to flail on the chest while you're driving 30 miles to the medical center, that's a mistake.
Interesting. Thank you for that. And then I guess the only other thing I was going to comment on was just the AHAT. I just thought that was so interesting. And I'm just wondering, I guess, physiologically, anatomically, it's an external kind of effect of the REBOA. Is that how I'm understanding it? I'm just trying to visualize it it's like a tourniquet for the aorta. So essentially, and I'm wondering, just a cost and a skill comparison, it seems much easier, right? I'm sure it's less occlusive completely, but I just think that's an interesting concept, and I'm just wondering if that's going to kind of expand over time, because it seems like much easier to apply, right, and utilize for interim control. So that was it. Those are my thoughts.
Yeah, no, great thoughts, Jeannie. Thanks for that. Yeah, the AHAT, I mean, it's now in its second iteration. The one that's out there now is a little bit more user friendly than the original. And it's doing that. But people will also argue, why spend $300 when if I can just get a beefy guy with a fist to go between the belly button and symphysis pubis and just put all of his weight into it. So I don't know. The verdict is still out on that, but there is some good data that's coming out. And the use of junctional tourniquets, not that it's part of this talk in general, but there are a variety of different junctional tourniquets that have received different accolades for efficacy or no efficacy over the span of time. So this is an interesting one. Certainly when I'm teaching the TECC courses, or we're teaching field care to our tactical providers, it is part of the armamentarium of what we suggest they carry, because you know what, when you're out there and you've got nothing else to do, the thought would be a last-ditch effort might be that this could be restorative. But even then, we tell them if it's not restorative, you go on, you move on. The good of the many outweigh the needs of the few or the one, as Mr. Spock said.
Yeah, let me just amplify that a little bit. I was in Kosovo and then I was in Iraq for sustained periods of time, and we learn a lot from from our military experiences. And the 18 Deltas, the Special Forces medics, are literally on the cutting edge, and they, some of them are credentialed to put in Reboa, but the junctional tourniquet, the abdominal junctional tourniquet, is it's kind of the shiny new toy. But I think that the paradigm is shifting a little bit. We used to do a really quick evacuation chain from Vietnam and even Iraq and Afghanistan. You get a point of injury and you bring them right to a combat support hospital as quickly as possible by helicopter, and you make a big difference. But sometimes bad guys are everywhere, and you have to do prolonged care in place. And if you have to do prolonged care in place, or there is a delayed transport, or it's a very long evacuation chain, then we have to start thinking about, what are the other alternatives when you don't have a surgeon, an OR, and a blood bank. And these things like Reboa and these things like the abdominal junctional tourniquet, do get a little bit more attention. And they're not the panacea. And that's what we tried to say in the paper. They're still provisional and we're still thinking about them, but they're out there. And I do think that, for selected applications, they may have a place. So I'm keen to continue to follow.
Yeah, and I'm the same way with you. I mean, I've seen enough now with just some of these case clusters that are coming out of the Ukraine, to where even for my tactical groups, that we've actually went ahead and made the investment to have at least one of these with each embedded team. Just because sometimes even in the civilian world, you're in an austere setting where you're not going to be able to get them out because, again, there is a firefight going on. You are in a calamitous situation, and this could be a last ditch effort for you. And certainly, again, in the Ukraine, they're finding, that this very well may be the case. Still more information to come, but certainly something I think we do need to keep an eye on. All right. Any other questions from anybody? Great conversation. Thanks of you that contributed to me. All right. Well, I think that we'll try to wrap it up. So, for the sake of your evaluation, so if you can you want to pop the QR code here right now. I'm going to see if my copy and paste is going to work. Let's see here. Hopefully, it's working. Yes, it does. I love it when technology is good. So in the chat box right now is a link. If you don't have QR code ability, this will take you to SurveyMonkey, and you can give us your honest to God comments on tonight's session and what you found good about it, what you found was maybe practice changing, or at least practice considerational changing. We'd like to hear from you. That would be greatly appreciated. And then further to that, back to my right screen here for my next slide. Working with 3 screens here this late in the day can be undaunting. All right, boom. Again, next session of Topics in Trauma Nursing on Hemorrhagic Shock will be April 9th at 8 p.m. QR code is available there. If you don't have QR code ability, not a problem. Again, if you do the evaluation, just let me know you want to be put on the email list, and I will include you, and I will send information out to you with regards to this particular session. It certainly, I think, it tunes up to be very, very positive. And then without further ado, this is my contact information. So if you have any questions beyond tonight, please don't hesitate to reach out to me. And I certainly can put you into contact with either Joe or Molly if you have any questions tangential to the paper we discussed tonight. But again, I appreciate everybody's time and effort tonight, and greatly appreciate your coming on board, and everybody that interacted tonight. Greatly appreciate that. Fred, it was great seeing you again. Hopefully you're finding the weather down in Florida a little bit more agreeable than up in Maine at this time of the year, right?
Sure.
And but other than that, thank you guys for all tuning in tonight, and we will see you hopefully on the next session. So take care, and again, thanks for all of your time tonight.
Thank you, guys. Thanks for a great paper.
Thanks.
Thank you guys.
Hey.
Absolutely a great paper.